Bismillahirrahmanirrahim. Let's see the neonatal asphyxia. Neonatal asphyxia means the failure to initiate or maintain the spontaneous respiration within 1 minute after the birth. Okay, so if the after the birth there is problem in the breathing, so this is known as the neonatal asphyxia. What is the happiest start of life? Is nothing but the immediate cry after the birth. So the happiest start of this world, this life, is the immediate cry. Okay. So when you look at the baby after the birth, if the baby is vigorous, which term, so we just need a routine care. While on this side, you can see the baby with poor tone and color. It's a cyanotic, okay, who need resuscitation. So immediate cry after birth is the important moment, the golden moment of life. Okay. If you look at the epidemiology, there are 4 million newborn deaths, okay, each year. But and if you look at the epidemiology, so 4 million newborn deaths are occurring each year. So and 23% are due to asphyxia. Okay, although these are the different preventable conditions, but due to improper management, so these deaths are occurring. So in today's lecture, we try to understand the neonatal asphyxia and try to manage this condition. Okay, so first we need to understand the asphyxia. We need to understand the level of the asphyxia. There is no asphyxia, mild or the moderate or severe. So for the to classify the asphyxia, we look at the Apgar score. Apgar score is nothing but the 5 component A, P, G, A, and R. Okay, so we check out this Apgar score at 1 minute and at the 5 minute. Okay. Let's see what does mean by A, what does mean by P, G, and AR. Okay, A represent appearance of the baby. Okay, and the P represent the pulse. G represent grimace, which is the reflex irritability. Okay, and A represent the activity of the baby, and R represent the respiration. So these 5 components we're considering in the Apgar score. So and if you look representing the respiration. So if you look at the score, so there are 0, 1, and 2. Okay, 0 mean worst and the 2 mean best condition. Okay, and if you look at 5 component, mean total is the 10 and minimum is the 0. Okay, in the appearance you see the baby. If it's all blue, score is 0. If it's all pink, the score is 2. But if the only the extremities or the limbs are the bluish or the main cyanotic, okay, so this is the score 1. If you look at the pulse, if the pulse is absent, score is 0. If it's less than 100, score is 1. If it's greater than 100, the score is 2. In the grimace, you see the irritability reflex. If there is no response, score is 0. If there is a grimace, or you can say there's some changes over the face and a weak cry, so score is 1. If the stronger cry and the baby pulls away, okay, so this is a score 2. And in the activity, you see the movement. So if there is no movement, the baby is floppy baby, so score is 0. If there is active movements of the upper limb and the lower limb, so score is 2. But if you see only flexed arm and legs, so the score is 1. And the respiration, if there is no respiration or the absence or apneic, okay, score is 0. If there is a slow irregular breathing, score is 1. If there is stronger cry, the regular breathing, okay, so score is 2. So overall you see the score for the asphyxia. Okay, if the total score is 8 to 10, mean there is no asphyxia. Okay, if the score is total score is between 5 and 7, so mean there is a mild asphyxia. If the total is 3 to 4, so mean the moderate asphyxia. If the total score is 0 to 2, so mean there is a severe asphyxia. Okay, so this is the value of the Apgar score. We check at the 1 minute as well as and at the 5 minute. Okay, if the baby does not start the crying, severe asphyxia, we go for the resuscitation and look at the Apgar score at the 5 minute. Okay, so the baby is improving or not. If you look at the text side, so how we define the neonatal asphyxia: failure to initiate and maintain spontaneous respiration within 1 minute after the birth. Okay, so incidence is 2 out of the 1,000. The neonatal, perinatal, or the birth asphyxia, so these are the same terms. In all the condition, there is a impaired gas exchange in the first and the second stage of labor, so which lead to the three important factor. Okay, fetal acidosis, hypoxemia, low oxygen in the blood. Okay, and hypercarbia, due to hyperventilation. Okay, so there are high level of the CO2. So three terms usually you see: neonatal, perinatal, and the birth asphyxia. So these are the same terms. Okay, so and their mechanism is, what is happening is all these conditions impaired gas exchange in the first and the second stage of labor, which lead to three important components: fetal acidosis, hypoxemia, and the hypercarbia. The acidosis mean the pH is less than 7. Okay, and the hypoxemia mean there is low oxygen in the blood, and hypercarbia mean there is a high level of the CO2. Okay. Okay, so this is the start of the asphyxia. Okay, so which lead to the hypoxic ischemic encephalopathy, mean the involvement of the brain. Okay, due to this, there is abnormal neurobehavioral state. Okay, so we define in form of staging. Okay, Cerner staging for the hypoxic ischemic encephalopathy. So there are three stages basically. Stage 1, where the baby is irritable. The normal tone, the reflexes are high, but there is no seizure. Okay, so this is the stage 1, which has good prognosis. In the stage 2, there is a lethargy, hypotonia, weak reflexes, and the seizure are the common in the second stage. Okay, and the prognosis is better than the stage 3. Where in the stage 3 there is a poor prognosis, where you see the coma and the flaccid. And the reflexes are absent, although there are no seizure, but it's a coma stage. Okay, where you see the baby has a very poor prognosis. Okay. So these are actually the basic concept or the background concept which we are further discuss. So let's look at the neonatal asphyxia in a clinical terms. Okay, when the Apgar score is less than 5 and for more than 5 minutes. Okay, so you see the metabolic acidosis and the abnormal consciousness, which is mild to severe depending upon the stages. Let's look at the neonatal asphyxia clinical definition or the clinical aspect of the neonatal asphyxia. What you should appreciate to diagnose the neonatal asphyxia. So Apgar score is less than 5 and for more than 5 minutes. Okay, and there is a metabolic acidosis and there is abnormal consciousness, which is mild to severe. Okay, and there are abnormal reflex and the motor abnormality. We start with the hypotonia. Okay, and later it become the spastic. Okay, and you in the 50% cases you see the seizure in the first 24 hours. And multi-organ dysfunction due to impaired gas exchange, and the most commonly affected organ is the renal or kidney. Okay, and then the brain, then heart, and then the lungs, and then the bowel, mean GAT, liver, and bone marrow. Okay, so but the most affected organ is the kidney. Okay, where you see the acute tubular necrosis mostly. In the etiology, the main factor is the impaired placental gas exchange. So this is due to either a maternal factor or due to some fetal factor. Okay, in the maternal, so there is a decreased placental perfusion due to preeclampsia, severe hypotension, or the hypoxia, or decreased placental gas exchange, like in the uterine rupture or in the placenta abruption. Okay, or due to decreased umbilical blood flow. Which you see in the umbilical cord prolapse or the umbilical cord compression or the abnormal umbilical vessels. Okay, so these are the maternal factor. If you look at the fetal factor, if the fetal is compromised, like in anemia or in the infection or intrauterine growth restriction, so this lead to the impaired gas exchange. or if there is no cardiorespiratory adaptation after the birth. Okay, so you know better, there are some changes occur before birth and after birth. If you see here, so there is, if you look at the oxygenation, although it's a low in the prenatal, after in after the birth, in the early postnatal period, so oxygenation increase and the oxygen metabolism also increase. Okay, so these are different changes occur after the birth. If the neonate unable to adapt these changes, so this may lead to the neonatal asphyxia. Okay, if you look at the pathophysiology of the effect of the neonatal asphyxia, so start with the perinatal asphyxia, which cause the hypercapnia or the hypercarbia, hypoxia, and the acidosis. Okay, this lead to decreased ATP production, of course, and decrease the enzyme activity due to acidosis. Okay, and there is a arterial vasoconstriction to because due to hypoxia, so they try to maintain the oxygen level, so there is arterial vasoconstriction, and you see the cerebral hypoxemia. Okay, so all the other effect you see, these are secondary to these the initial changes. So due to low ATP, so there is increased extracellular potassium, which lead to the acidosis and which lead to the myocardial dysfunction, mean the cardiac failure. Okay, and due to decrease in enzymatic activity, so the surfactant synthesis decrease, which lead to what, the respiratory distress syndrome. Okay, and due to arterial vasoconstriction, so affected area is the peripheral bed. Okay, so when the renal bed is affected, so this lead to acute tubular necrosis. When the mesenteric bed is affected, so this cause the necrotizing enterocolitis. Okay, when pulmonary bed is affected, so this also decrease the surfactant synthesis, which cause the respiratory distress syndrome. Okay, if you look at the cerebral hypoxemia, which increases the cerebral blood flow. Okay, and which cause the hemorrhage and the seizure. Okay, and the hypoxemic encephalopathy. Okay, although this is the detailed picture of the pathophysiology of neonatal asphyxia, in short, you should remember hypoxia cause respiratory depression, and the hypoxia and the hypercarbia causes the metabolic acidosis, which lead to shock and the multi-organ systemic failure. Okay. If you look at the investigation of neonatal asphyxia, so there are some prenatal, some the perinatal, and some postnatal investigation. Although the prenatal is for the gynecologists or the obstetrics, okay, where they go for the fetal biophysical profile and the Doppler ultrasound to assess the cord blood flow. Okay, so here is the biophysical profile where a consultant assess the fetal breathing movement, the fetal movements, fetal tone, and the amniotic fluid volume. Okay, and the score is 2 or 0. Okay, and depending upon the overall score, we have different management option. Okay, in the prenatal cases, and then the double ultrasound, this is in the normal pregnancy. You see, this is the this show the systolic, here show the baseline of the diastolic. If you see this gap is coming down, so here you can see this is reduced in diastolic volume. Here you can see there is a absence of the end-diastolic volume. So you look at the gap in between these curves. Okay. And in this case, you can see there is a reversal of the end-diastolic velocity. Here you can see the different result of the Doppler ultrasound. In the normal Doppler ultrasound, you look at the end diastolic volume. So at this level, we are considering the end diastolic volume baseline. Okay, so this is normal. Here you can see this is reduced, and here is the absence of the end diastolic volume. And in this case, you can see the reversed. So these are the alarming sign. Okay, so this is the normal pregnancy. And here also you can see the normal baseline, and here the absence of the end diastolic volume, and here is the reversal of the end diastolic volume. In the perinatal investigation, we look at the blood gas analysis and the saturation. And this is important for the acidosis. In the postnatal investigation, so there are some labs investigation and some imaging investigation. In the labs, we monitor the arterial blood gas and look at the blood glucose and the temperature, electrolytes, and the kidney function test and the liver function test to assess the multi-organ dysfunction. Okay. And in the imaging, especially associated with the brain involvement, okay, cranial ultrasound and EEG, the echo, and the MRI to look at the lesion of the basal ganglia and the thalamus. Okay. So 4 and 14 days. And the prevention for the neonatal asphyxia is a good perinatal care and the decision when to do cesarean. Okay. Management of the neonatal asphyxia, number one is the proper stabilization, the vital stabilization, which minimize the neuronal damage. Okay. And supportive therapy, the open airway, the oxygen therapy, and the IV fluids, and the head cooling therapeutic hypothermia, where we try to maintain the rectal the temperature between 33 to 34 Celsius. Okay. And the body cooling, so this also decrease the brain damage. Both head cooling and the complete body cooling, so this decrease the brain damage. Okay, so if you start within the 6 hours after the birth. Okay, so here you can see the hypothermia. Here is you can see the head cooling cap. Okay, here is the complete body cooling. So this decrease the brain damage. Okay, and the supportive therapy for the multi-organ dysfunction. Okay. And also we continue the supportive therapy for multi-organ systemic failure, like the renal damage or the brain damage, heart, lung. So we also take care of these organs. Okay. And the anticonvulsant like phenobarbital and phenytoin, which prevent from the seizures. Okay. And give volume and inotropic support for the hypotension, and give the 10% glucose if there is hypoglycemia. If there is hypocalcemia, give calcium gluconate IV. Okay. So this is all about the neonatal asphyxia. Thank you very much. Allah Hafiz.